I was going to ask, I know your hands are a little bit different from some of your friends. Is there anything that you struggle to do that they can do easier?
Can surgery improve the quality of life? And if we look at it, it has a great potential. If we do good surgery, appearance is better, function is better, activity may improve.
Alessandro is a very strong personality. I never had the impression that he felt not being like the other children. This feeling of trust, of confidence to a doctor is, for me, it was so important to give like a year-old, it was my firstborn, a year-old boy into the hand of surgery, anesthetic.
We were discussing so much about surgery, so much about different procedures, outcomes, angles, forces, but actually what we all aim for is having happy patients and maybe to live happily ourselves. So this session is not about the angles and the technique, it's about happiness. So I feel privileged to have one of my friends, former patients with me, Alessandro, you're the most important guy. He's accepting to do an interview with us. Then his whole family is here with Simone. Then we have an expert, Jill Smith, who does not need any introduction, I'm afraid. And we got Ursegli, an attorney from Zurich, who is sharing reflections on happiness. So we start that with an interview, and since Alessandro is not fluent in English yet, we will try to translate.
Alexandro, I've heard rumor that you play soccer.
Ja.
What position do you play?
Stürmer.
Frontman.
Do you score many goals?
Veel goal.
Ja.
And how often do you play?
2 Bälle im Montag. Eins Match.
Twice a week and a match per week, so that's 3 heavy setups.
So it's 2 practice sessions and 1 match, is that correct? Last week, did you play in a match?
Ja.
Did you score?
Ja.
How many?
Das Großball 3 und 10.
5!
Oh, so in the big field it was 5, and in the small one it was.
Wow. That's amazing. And do you play for a team?
Ja.
Who?
Welche Verein spielt?
Interlaken.
FC Interlaken, very famous. From now on, all over Europe.
Do you know what you want to do when you're grown up yet?
Fußball spielen.
So he's going to be a professional soccer player, of
And
course.
who are you going to play for?
AC Milan.
Ah. What else do you like doing?
Machst du sonst noch etwas gern?
Alkoholhalle.
Jump Factory.
Okay, fair enough. And how? Do you have a best friend?
Matteo.
Okay, Matteo, does he play soccer too?
Ja.
Yeah. And is he as good as you, or are you better?
Basically.
Same.
Same. Okay. I heard that you had some surgery when you were little.
Ja.
Do you remember any of it? Yeah.
No memories.
And do you go to the hospital and see the doctor still?
Ja.
Yeah. How often do you go and see him?
Every 2 years,
Okay.
over the last years.
And what's it like going to the hospital? Do you enjoy it, or is it boring, and do you get to miss school?
Manchmal ist cool und manchmal ist langweilig.
Sometimes it's cool, sometimes it's boring.
Okay. And do you get to miss school to go to the hospital?
Meistens.
Yeah, you usually miss school.
Okay. What do you like doing at home?
Manchmal nervt.
Teasing his little sister.
Ah, so Aurora gets a hard time. Trying to think of anything else to ask you. He's been so good.
Is there anything he's different from other kids in the soccer team? So he's not aware of that.
No.
Any worries in soccer? Defense is difficult.
After the game, do you have to go and shower?
No,
Ooh.
I don't do that in Switzerland anymore.
Smelly.
It's a big issue in sports
Okay,
nowadays.
right.
They shower at home. Yeah.
Okay.
Cool.
I was going to ask, I know your hands are a little bit different from some of your friends. Is there anything that you struggle to do that they can do easier?
To be a goalie in defense. Und sonst im Alltag, sonst in der Schule, kannst du alles machen. So basically does everything.
If you're a goalie in defence and you're in a good team, you don't have any work. So it's better to be at the forward. I suspect you prefer scoring goals rather than stopping them. Is that true? So you wouldn't want to be goalie anyway.
I think it was nice to have Alessandro. Give him applause. And thank you for being with us. And we will share some thoughts, which I will give a short introduction. Then comes Jill. And most importantly, mom of Alessandro. I think it's important that you get to know Alessandro and his family. When we see him and many other patients, we see that all over, they're very happy people. And when we go into the literature, it's being confirmed that children with hand have a good life and a good quality, with hand difference have a good quality of life. However, when you go to recent literature, we see the buts. So several factors may negatively influence quality of life in children. And when we look into literature, we see that having additional malformation obviously is a big issue. Some have like esophageal atresia and many other associated anomalies. Socioeconomic factors are a big issue. The poor families suffer more than those who are in good situation. Age group, teenage years are difficult. And race is an issue. In US-American studies, the black had a poorer outcome of quality of life than the others. Now, if you see that, I think surgery can be a solution. So if you do surgery, the question is, what happens with these children? Obviously, surgery is very powerful to change appearance and function. So can surgery improve the quality of life? And if we look at it, it has a great potential. If we do good surgery, appearance is better, function is better. Activity may improve, so if you have a better function, you can have a higher autonomy and dress yourself. And participation may improve as well, so it has a potential. However, when we look into the same article I showed in the very first moment, there's a subgroup of patients, and they differentiate within those with severe malformation, which you cannot correct completely, like a radial longitudinal, as in Alessandro's place, and those with mild deformities like syndactyles. And paradoxically, those with mild malformation suffer more. So if we make a surgeon's malformations milder or less severe, does not automatically mean that we improve the quality of life. So I think it's important to be aware of that dilemma. And why is this so? I think there is so many negative factors that go along with surgery. There is pain, there is immobilization, there is hospitalization. You cannot have your activities, you cannot participate while you are in pain. There is scars that also have an effect on appearance. So these need to be balanced against the benefits of surgery. And what we have not talked yet about is the positive parts of these children. Why do they have a good life? Many of them have a great family support, and the family helps them to build up resilience. Now, if we do surgery is in many aspects not respecting children. So I think one of the first and most important thing that we need to see, which is relevant, is unconditional love. that parents and whoever is together with these children say, it's okay the way you are. There's nothing wrong with you. You have a difference, but you're not ill. It's okay the way you are. So that's unconditional love. But at the same time, we say, no, it's not okay. We fix it. We go to take your surgery. We change your anatomy. So this dilemma it needs to be reflected by ourselves. And I think it's important that we realize that we disrespect the autonomy of these children. What other approaches do we have? And if you look at that first slide, when we see the quality of life, we have our occupational therapy. Occupational therapy is all about function, activity, adaptive strategies, and we should always remember that this can be done independently from surgery. The same goes for psychological support. We saw that there is some families at risk who are maybe less favorable, less good off in society, who have more poverty or other stress factors, so they do need support, and we need to realize who these families are and try to do our best so they get the support. So we can always have the conservative treatment, this occupational and psychological support, and if we do that in an interprofessional framework, surgery may have a role as well, but I think it must always be in a team. As surgeons or as doctors, we always had that saying, or the Hippocratic oath, do no harm. But many forget there's two more, be cautious and heal. And as surgeons, I think we must be aware we cannot heal. So all we are left with is do no harm and be cautious, whatever you do. Thank you. Now I'm handing over to Jill. And Jill Smith is a very experienced consultant for Great Ormond Street. And I think you're great with children, and you have so much to share what you experience and what you share. Jill.
I asked AI, just what is a first consultation? And they said it's an initial exploratory meeting designed to establish trust, understand specific needs, and define a clear action plan. And this was just any first consultation, not even a medical one. But I thought that was quite good in terms of what we want to do. And that first thing is establish trust. I'm going to talk briefly about how to manage the family's concerns and how to examine the child. When you're expecting a new baby, it's a new addition to the family, it's a cause of great happiness and expectation, and you expect perfection, and there's little books that have 10 fingers and 10 toes, and it's anticipated for months ahead. But then suddenly, what you find you're having is not the baby you were expecting. And that might be discovered antenatally, perhaps in a radial longitudinal deficiency or a transverse arrest, although it often isn't. Most commonly, the difference is found at birth, but some things will show up afterwards or much later on. And the parents have similar reactions. They're shocked, not in the clinical sense, but this was not expected. They've been anticipating a certain child, and they've got a different one. And they're often very upset. Later, if they present in childhood, the difference is not the same. The parents' reaction is different because they already love the child they've got, even if there is something else and they just want it sorted. But when you've got a new baby, you're expecting this perfection and you get something different, and sometimes the parents can't see beyond the difference to see the wonderful child they've got. And what you get as a doctor will depend on when you see them, where the parents are in that stage. So it depends when your consultation is. And how much the parents will be able to take in is also dependent on when your consultation is. But quite often they're not going to get everything the first time. So the parents of either an antenatally or at birth diagnosed child are going to find, they're going to go for a grief reaction, just as though they've lost somebody, because they've lost the child they were expecting. They got a different one. And it takes a while to accept that that different one is just as wonderful, just different. apart from the grief reactions and going through the normal cycle of grief, sometimes they'll blame each other. Almost always the mother will blame herself. She'll search through her pregnancy history, trying to work out what she did. You know, even crazy things like, you know, should she have laid in a different way in bed that made her child different. And sometimes they'll try and hide their child away and become socially isolated. They may reject the child. And quite often the father in particular the father, will be going searching the internet, searching for doctors for a cure. So antenatal diagnosis, you as a doctor may get referrals, although they're not always sent on. And the parents are going through the same grief process as postnatal, but they're doing it before they've actually got a child to hold in their arms. They may consider termination of pregnancy. So when you get these referrals, you're very time limited and you have to see them urgently. And sometimes the expectation at that point is very unrealistic. Antenatal diagnosis is difficult. Ultrasonography early on basically just says the hand or the foot is on the end of the limb and not very much more. And at 18 to 22 weeks, if you have a scan at that stage, which we do in the UK, but not all countries do, you should be able to identify much more. But it's only relatively recently that in the UK they suggested you should check a hand is there, let alone fingers. Fingers are quite difficult to see because the fetus often has their hand fisted, and it's only if it's wide open they can see. In the third trimester, actually you can see very little because the acoustic window is poor, and more often you might need an MRI there to see something useful. So an antenatal consultation is an urgent, unexpected referral to the doctor. And actually you often have very little information at all, which makes it very difficult to prognosticate and to tell the family what to expect. The family need time to process this, and sometimes they'll need other people to help in decisions. And when you see them, you definitely need to be separate from a busy clinic. You need to be in a quiet space and have some tissues there, because the mother's often very hormonal as well, obviously. And be non-judgmental. It's up to them what they want to do in their lives, not you. Postnatal diagnosis, there's different things, because then you have a whole family involved. And usually you're seeing babies, and there the parents are obviously the major influence, but grandparents, particularly in some cultures, have significant influence. And siblings, and concern for the effect on other siblings, is also another thing that comes into play. Now, if they present when they're in school, the teachers may have an effect, both in come in and sending the child to see the doctor, but also in their opinion on whether something should be done, even though they may not be educated in that area. And then when they present as a teenager, it's often to do with cosmetic differences, and their peer group is important, as well as their teachers. So what do the family want to know when you first see them? And it usually is a baby. So what's the diagnosis? Why did it happen? Was it something I did in the pregnancy or before? And what else? Is there anything else? If this on the outside looks different, is there something else wrong with my baby inside? And if I have another baby, will I have one the same? And what happens when my child wants to have children? Will they pass it on? Other questions you might be expected to answer is, how are you going to sort this out? When? Will my baby look normal? Will my child get teased? How will my child manage in life? And if treatment's optional, well, can I just leave it to them to decide when they're older? The answers aren't all there. You may need colleagues, assistants, and especially genetics. You may need to explore with the family if there are concerns about etiology in terms of, did they drink too much coffee or something. There's lots of things that parents worry about that you might think is daft, but it will ease their worries. Children get teased at some stage. They'll get teased about something, but it may not be their hand. And most of them are wonderfully adaptive, and they use what they're given to its optimum. The timing on surgery depends on multiple factors, including what the family want, what the child wants when they're older, what the condition is, what facilities you have. Very few surgeries create a normal hand that's the same as yours. And congenital hand conditions have got lots of different approaches. But here comes the rub. You're treating a family, and the baby hasn't got any say. Actually, you're treating someone that doesn't exist, because what you're trying to treat is the person that that baby, that child will become as an adult. And even the parents don't know what that will be. And they spend more time with them than anyone else. And those making their own decisions, the decisions about this child often have their own biases, including the wider families, you yourself, and of course, internet and social media have a huge say now. So what's your role as a surgeon? Well, diagnosis, education, telling them if we don't do anything, this is where we will go, and that's only if we know that information. Giving them options for treatment, which they can choose which they want once they've got that information. Giving them guidance on where probably is not such a good option, and then support through childhood and beyond. Surgery is only a small component and may not be necessary at all, because it isn't the foundation of happiness. In fact, your chief role is educating the parents so that they can support that child and empower them for the future. What about examining a child? Well, children aren't small adults. They're mentally and physically different, and they react differently. And actually, when you're a bit older, like Alessandro, visiting the doctor can be quite scary. The parents, when they first come, are usually nervous, and the child will pick up on that. Even a baby will pick up on that. And we tell children to be wary of strangers, and then we ask them to undress and prod them. Well, I mean, that's a bit of a dichotomy, isn't it? They may have had previous experience if they've fallen over and injured themselves, and maybe have been held down and have become distressed. And some of the older children and the brighter ones use a bit of bribery. You know, what can they get out of their parents to be able to be a good child? I have a number that end up going to McDonald's after their appointment. I would say keep your distance. Don't crowd the child. Give them their space. Get their trust. And if you can get down to their level, that's good. I spend a lot of time crawling around the floor in my clinic. I'm not so good at getting back up again now. Explain what you're going to do before you do it, much more than you would with an adult. And one of the fun things is sometimes ask them to copy you. So you can lift your arms in the air and you can pretend you're an aeroplane and things like that. And then they will follow. Or they'll think you're crazy, one or the other. If they're really reluctant, they trust their parents, so ask the parent to do the test on them. And make it fun, play. And if you've got any scary things around, like pins and scissors and stuff like that, hide them. They do not need to see them, that's just more scary. If you have got something that's painful, go to everywhere else first before you go to that, otherwise you're never going to know anything. And if it's not essential and the child's distressed, just come back another day. I had a child the other day that screamed even before they got near me. They didn't even come in the room. And it turned out they'd been to the dentist with their mother and seen their mother have dental treatment, and they were very distressed. So we played with a few toys in the room, we waved at the child, and we sent them home to come back another day. So now they've had a non-bad experience that hopefully they come back next time, they won't be so worried. When you're trying to work out what's going on with the child, watch. Watch from the first moment you see them come in the room, if they'll come in. Watch while they're consulting with the parents, and watch until the moment they leave. You may not get to touch them at all, and the little ones, particularly when they're teething, do bite. You might be lucky and have someone like Alexandra, who I'm sure is excellent there, but sometimes they're not, and the 2-year-olds in particular are a complete nightmare and sometimes won't come near you. But you can look at what they look like, whether there's any different features. You can look for any obvious problems with anaesthesia, like if they've got a very receding chin. You can, if you get a look at the hand, look at what bends and what doesn't, what creases are present. if you can test for stability and muscle power, great, but don't put any money on it. And if you do, we have games. So my opposition, I get the child to put, and you can do this from a very early age, thumb to one of the fingers, maybe the ring or the little, and we have a finger fight, and he usually wins. But that's quite fun, and they'll play with that, and it works, and you can see what the opposition power's like. Look at the static differences, but also look dynamically how they use their hand. And they may use functional grips, and they may use adaptive techniques, and we've already heard about that. And you can see this boy with arthrogryposis is doing that on the bottom. Investigations, you don't need much. An X-ray is only going to tell you a certain amount because they're skeletally immature. So judge whether it's really going to be necessary at that first consult, and it depends on the age of the child and what you're dealing with. Ultrasound I love, but you need to have someone that can do it well. But most children will cope with ultrasound. What they won't always cope with is MRI, and I don't do them very often. You can get MRI in the first 6 weeks of life, but after that they often won't lie still enough until they're 8 or above, and sometimes not then. But investigations need to be those relevant to the condition, relevant to the associated problems, and to anaesthesia. You may need genetics referral, and hand therapy is really useful because I'm a scary doctor, my hand therapists are not scary, and the family will often discuss some of their other problems that they don't think are relevant but are with the hand therapist. You're often asked how to fix it. And the thing is, there's a huge spectrum of congenital hand differences, and one size does not fit all, and different surgeons do things differently. And surgery is based on principles, and the aim is to improve the long-term physical and social functioning, appearance and participation. But remember, you don't always need to do surgery for that. And the parents want to know, when can you fix it? Well, that depends on what else is wrong with the child, if there is anything else wrong, how big they are, how big the bit you're operating on is, how much is the chance it's going to get worse as they grow, in which case you may need to go earlier, and how complex is the surgery, because the more complex, then you maybe need a bigger child or a bigger bit. And then you have to judge, can I get a good result that lasts if I do it now or not? And you have to do a few and get them wrong before you realise where your limit is. What about if the family have unrealistic expectations? Now, I'm a plastic surgeon, so I don't know if the orthopods get the same, but I'm expected to cure everything with no scars. And I'm not God, and I'm not Harry Potter. I can't do magic. And I try and tell the patients that. And I will not operate until they have expectations that I feel are realistic, because otherwise they'll be disappointed and I'm putting that child through something. You should always operate for the child, not just to them. So what if the family can't agree? Now, this seems to be a happy family, but not all families are. And when the acrimonious divorce is in place, then sometimes the child becomes the ammunition between the parents. Try not to get involved in that, try to mediate. If they don't want something, there may be a cultural reason, it may be related to the grandparents' views. But don't do complex surgery without the agreement of both parents or those who have parental responsibility. What if they don't want surgery? Well, you don't always have to have surgery. We've heard from Daniel that happiness isn't dependent on surgery. So explore their reasons, explain why you feel it might be better. And quite often I'll say, you don't have to, like thumb duplication, you don't have to do it, but it's probably easier on the child when they're little than when they're older. If they live in a country where extra digits are considered lucky, fine. But if they live in England, they're considered a bit different, and that isn't always a good deal. And if you leave it till the child decides, it's going to be harder on them because it's actually physically harder to recover. They're rarely in danger, but if the parents decline surgery, therefore you can usually accept it. But don't just discharge them, offer to follow them up and support them, as the child might still need help as they get older. What if they want surgery that you don't want to do? Well, that is a moral and ethical issue, and you need to listen to them and explain your reasoning. I would suggest getting a second opinion from a reputable colleague. I personally don't perform surgery that I think is wrong, because I'm doing this for the child, not for the parents. So if I think it's wrong, I'm not happy to do it. If someone else wants to do it, that's up to them. What if the child doesn't want surgery? Someone like Alexandra is old enough to argue with me. So if they are young or have severe learning difficulties, then you can probably discuss it with the family. But for most hand surgery, I would not consider doing surgery unless a child of 8 or above agreed to it. Anesthesia and post-op compliance will be an issue. So in summary, restoration of anatomy in the lower limb is often enough to improve function. In the upper limb, you have to balance between function and aesthetics, and surgery often can't restore one or certainly both. You need to match the family's expectations with your own and take time to do so. An examination is more to do with observation than radiology, and play with them, it helps. You need to look at more than once to gain the child's and family's trust, and your best examination of a static deformity will be in the operating theatre. Thank you.
Thank you so much, Jill. So Simone Portman will share her views of a parent. So I think the beauty about having children with us is having long-lasting relation with parents, and they teach us so much, and we really need to listen to that. And I'm sure you're the one who's going to tell us.
It's very funny, when I was listening to the presentation of Miss Smith, she really, I think she explained my life. Like, what I was feeling before I got birth, the trust we had to bring up for the surgery, all the feelings afterwards, as you said, depression, fear, and especially the expectation. Since we had a few discussions with Professor Weber about how it looks like at the end. For me as a parent, it was exactly what you said. I wanted to have, like Alessandro, he was born with a radial aplasia, so 4 fingers and no radius. And for me it was clear the surgery in Switzerland is able to give me a hand with 5 fingers and equal to the right hand. And when we had the first discussions, it was exactly what you said before. Professor Weber told me, well, we can make it functional, but we cannot make miracles. And with the time, like we went into it, and at the end, as parents, it is very important to have, as it was told many times, a happy child, a child who is able to do everything. And in our case, we are lucky. Alessandro is a very strong personality. He's into the soccer, as you could feel before, so this gives him the support he needs to be like the other children. And I never had the impression that he felt not being like the other children. However, now he's in the age of 10. I mean, we don't have to be naive. Now is the age coming where I think that differences will be more important, and we will see what happens. And I think that the importance of us parents or family, as you said, it's relevant, is to support him and to build out of him a strong personality that we can get, that he can work these things out. Yeah.
From your experience as a mom, what's the let's say the not to do's when people come in? We always, I mean, Jill told us what to do. So is there not to do's? What's offending a parent when you come in a very fragile moment of your life?
Well, that's a really good question, because we had this many times when we had him in the children garden first, like the teachers, they didn't know, shall we say to the whole class or we shouldn't. Like we as a parent, we always took him as he is, and for us for me there is no question people cannot ask. Because I think he's perfect like he is, and that's why, I mean, if someone or if children are too fat, I mean, you are exactly in the same situation as parents. So for me, there is no question not to ask. It's probably the way how you ask.
Were you sometimes hurt by doctors or health professionals?
Hurt in sense of mental hurt?
They made you feel bad?
Well, this we had many times when we went to doctors. His whole left side is not very well developed, so he can't hear very well on the left ear. And when we went first there, they told me, yeah, he's not going to be he will never play piano well. He's not going to be a pilot, and it was like. But we are not talking about here what he's not going to be. We should talk about what is the disease. I think this was, for me, this, I think, brought me really in an uncomfortable emotional situation. This is something I think a child should not hear. It's not because of me, but it's because of him.
So it's more about potential and strengthening and positive messages.
Yes, yes.
You've got a group of doctors here. Is there messages from a mom which you say, well, next time you see a child, don't forget?
For me, I tell you, the most important, I was in the environment of the University Hospital of Bern while I got birth of Alessandra. I was working there. And so I was quite well connected to different doctors. And for me to know who is going to make the surgery on my son was very, very important. And this feeling of trust, of confidence to a doctor is, for me, it was so important to give like a year-old, it was my firstborn, a year-old boy into the hand of surgery, anesthetic. For me, it was really, this was, I think, the hardest part. And when I met Professor Weber, for me, everything was clear. I was like, there is a trust in, and I could let it go. And I think this is the most important part when I think back of it.
I think as doctors, we have to remember that probably the most precious thing in your life is your children. And to give that up and give them to someone else to operate on, it's a big deal.
Especially, you know, the way you do from birth until this part is already very emotional. And then when it really comes to this day that you have to give your well, it was my newborn with 1 year, into strange hands, I think the feeling of trust, I think this was the most important for me.
I think I would say, and I'm sure many in the audience feel the same, things don't always go right. And when they don't go right, you've gone in with the family and you need to continue to support the family so that, you know, they trust you to look after their child. And everybody in this world knows that things don't always go the way you want them to. And if they don't, you need to continue to support them. As a surgeon, if anything doesn't go right, you want to back away and run away, but you mustn't. You're there together with the family, running forward. And you are there to make sure that they can bring their child up and they have the confidence to bring their child up as a resilient individual that can manage in life. And that is not to do with surgery.
Well, thank you very much. I think it's a beautiful statement to hand over to the next. Thank you very much. It's teaming up with the families, which is very important. And one man who impressed me very much was Urs Egli. He's an attorney at Zurich. And basically, he gave a talk on how to work better. But I think if I work better, that makes me happy. So I think after all these days where we were suffering, struggling, working, I think it's important to find balance and happiness, and I think you're the expert.
I'm going to talk about us as professionals. I'm doing that as a lawyer. Why do I speak here? Because first, Daniel asked me to do it. And second, because I think there are some strong links between our two professions. Doctors and lawyers, we both want to help people. Doctors by curing the body and the mind. Lawyers by helping clients in difficult social situations and in finding peace of mind. Thus, we both work first with the needs of our clients and second with their minds. When patients come to us, they tell us about their pain and their wishes. But often their wishes do not match their needs. Another parallel is that our professions are prone to the helper syndrome. That is a major risk for stress, losing focus, and ultimately purpose. Our patients and clients need happy doctors and lawyers. Let me share some of my thoughts which brought me here today. Peter Fischli and David Weiss were a Swiss artist duo. You might have heard about them. One of them already died, unfortunately. One of their important artworks is How to Work Better. While traveling through Thailand, they came across this list pinned on a wall in a factory. Have a look at it. I really like it. I have favorites, maybe you too. My favorites are 6, change, and 10, smile. They painted it on an office building in Zurich. It's still there. It was also displayed in New York and other places later. This How to Work Better inspired a lawyer friend and me to apply this to the legal profession. When becoming lawyers, we study legal knowledge. Let's call it core legal knowledge, that is what is the law and how to enforce it. When starting my legal practice, I realized that it needs a lot more. How to talk to clients, which legal cases are worth taking on, how to make a living out of what you do, how to deal with clients' expectations, how to handle courts. Nobody taught me that. During the years, I realized that practical knowledge, not core legal knowledge, distinguishes good lawyers from mediocre ones. Let me briefly guide you through a selection. It's a personal selection. I selected those I thought might also be of interest with you. I start with number 1, clarify the mandate and assess the fit. The most important thing in my profession starts right at the beginning, when a client the first time sits in front of me and tells me what he wishes. He wants something from somebody else, or somebody else wants something from him. Apart from this claim at stake, I know nothing. Well, I know that the social or economic situations are always very complex. That's general knowledge. Things happened. I know that things happened and that people acted and reacted and people are personally involved and maybe hurt. Stakeholders are behind the clients and the situation is complex. I also know that psychology plays a big role on how people cope with conflicts. But I don't know what kind of person is in front of me. Is it somebody who tends to project the conflict causes on other people? All that I must find out. And when I have finally an idea of what it is all about, I must decide whether to take on the case or not. This decision requires a clear view on my own competencies and my preferences. Is the work the client wants from me something I'm able to do and I'm willing to do? Let's exemplify this with a mobbing case. Assume that the mobbing victim seeks the support of a lawyer. The victim tells the story from his point of view, how it has been treated unfairly and hurt. However, this is a personal view. The company most likely sees it very different. The company will say that it is all the fault of the mobbing victim, and in a legal case that will be brought up, it will all turn around deficiencies of the client. That is very hurting. That is very hurting. And that's why I made the decision long ago that I never will bring mobbing cases before court. I believe that mobbing victims are generally better off if they leave the issue behind. When I was still practicing litigation in court, my legal intervention much more often led the client to deal with the matter differently than he intended before seeing me. Knowing which battles to fight is as important as knowing how to fight them. Achieve results. What is the result of a legal intervention? It's not like in the construction business, where you can clearly define and measure the results. I also think doctors are much better off here. You can see what happened after you made your intervention. People who look for my advice, how do I measure it? What I do for them? The only measure is that the mandate eventually comes to an end. I go with my clients for a certain time in their life through a difficult situation, and I hope that the situation is at an end and that it could be of some help. That is the only objective measure of success, that a mandate comes to an end. The worst outcome, on the other hand, are never-ending mandates. Then something clearly went wrong. As a young lawyer, I thought success is achieved when representing clients before courts or influencing opposing counsel, judges, or commercial clients, other parties. I thought working with the opponent of my client is the center of my job. A couple of years later, I noticed that clients could be sufficiently happy with my services if we didn't completely win. Thus, I switched my focus. As I noticed, it's the client in the center. I work with him. That is the topic of my profession. But clients are sometimes difficult. In fact, they often are. It's mostly for a reason that somebody gets into legal troubles, and working days are stressful. Helping clients helps them, hopefully, but did it make me happy as well? A few years later, I realized that the lawyer colleagues I work with are what make my working days pleasant. Clients come and go, colleagues remain. Therefore, during my whole career, I gave top priority to interactions with my legal colleagues around me, even during my fullest working days. Lately, I came across a video reel of Jack Ma, the founder of Alibaba. It's called Find a Good Boss. You can look it up on YouTube. It goes like that. Between 20 and 30, find a good boss and learn from the person. It mustn't be a good company. Between 30 and 40, try to do your things yourself. You still have time in professional life. You can make mistakes, you can correct, but do it yourself. Between 40 and 50, do what you are good at. You have learned from a boss, you have tried, and now roll out. Between 50 and 60, spend time supporting young people. And after 60, spend time with your grandchildren. I came across this quote when reading books of Irvin Yalom, an existential psychiatrist. In some of his books, he focuses a lot on the fact that we all eventually die. And that this finite nature of life is exactly what gives our lives value. We should make something out of it. Schopenhauer was a bit of a dark guy, so is seeing the dark sides, but the idea behind it I like very much. Lawyers are in danger of getting eaten up by the work they do. They get drawn into the client's lives. When you go to a lawyer, you really have a big problem. Otherwise, you wouldn't go. Then you place this problem on the lawyer's desk, and then it's the lawyer's problem. And that sucks energy. You dive into the client's life, and really it takes you in. Doctors also see patients, but they see more than we. And that might be a reason why it's less dangerous to get too strong identified with the client. If you only see a client a day or even per week, this danger is big to identify yourself with the client too much. Diving into other lives or other problems sucks energy and vice versa. I see some colleagues, lawyer colleagues, who take energy from the cases they handle. That is not good. That is really not good. And we are not told that. We have to learn it by ourselves. The best way to treat this problem you see here on the screen is to have a strong foothold in your personal life. What do you have apart from being a doctor? Do you have friends? Do you have hobbies you burn for? I hope you do. Blessed are the ones with families. Families are time eaters and value givers. I always liked young lawyers with family and children. Children are a natural barrier against self-exploitation. Thus, when you leave this conference, you might find time to think about what you are apart from being a hand surgeon. Thank you very much.